Boa noite a todos. É um prazer estarmos iniciando mais uma atividade da SOBED Nacional. Hoje nós teremos o prazer de receber o professor Cheyenne Varadala-Gilu, dos Estados Unidos, uma pessoa extremamente conhecida de todos na área da ecoendoscopia. Ele vai abordar o tema de erros em neoplasia cística pancreática e como evitá-los, e nós teremos na moderação o Dr. Celso Ardengue e o Dr. Luciano Okawa. Thanks, Cheyenne. Thanks the opportunity to participate with you in this great event. Go ahead.
Thank you. Thanks so much for the kind invitation to be this evening. So I've been assigned by the organizers of this session today to talk about pancreatic cysts and to primarily talk about pitfalls in pancreatic cysts. So to avoid pitfalls, the most important thing in pancreatic cysts is to evaluate them correctly and to survey the cysts properly. So with this objective in mind, this is the burden of the problem. Pancreatic cysts are now commonly seen in approximately 2.6% of outpatient CT scans that is being done across the country. And these cysts are seen with increasing frequency as the patient ages. So patients age 60 and above are more than likely to have more cysts compared to younger patients. So when we look at pancreatic cysts, there are three different kinds for all simple reasons. Some cysts have no malignant potential. We don't have to worry about them. Pseudocysts, serous cyst adenoma, a lymphoepithelial cyst, a retention or a congenital cyst, and a lymphangioma almost never become a cancer. There are about 30 to 35 reported cases of a serous cyst adenoma becoming a serous cyst adenocarcinoma. But again, they are case reports described in the literature. The course is benign, although they can be locally infiltrative, and patients tend to live longer and remain asymptomatic. The cysts that we are always concerned are those cysts that have not become a cancer but have a potential. And these are two cysts. One is IPMN, and the second is mucinous cyst neoplasm. And IPMN, as we know, are of three types: main duct, branch duct, and the mixed type. So the main duct IPMN has the highest risk, followed by the mixed type, and then finally the branch duct type IPMN. Then there are some cysts that eventually become a cancer, and we know them all: pancreatic adenocarcinoma, neuroendocrine tumor, solid pseudocystic papillary neoplasm of the pancreas, pancreatoblastoma, acinar cell cancer, and sometimes a cyst adenocarcinoma. So the outcomes for pancreatic cysts are much better when they are pre-malignant than when they are malignant. So now when a pancreatic cyst becomes a cancer, the 5-year survival rate significantly drops to 25 to 30% if there's a cyst adenocarcinoma. On the other hand, if the cyst is treated when it is in a pre-malignant phase, then the 5-year survival, if the surgery is successful, is almost 100%. Therefore, it is very, very important to stratify these cysts and to evaluate them appropriately. So when we obtain a clinical history from a patient with a pancreatic cyst, some questions are very important. There are 5 questions that are critical. 1, if the patient doesn't smoke or drink, but has a history of acute pancreatitis. 2nd, if the patient has got a jaundice, and if the jaundice is because of a cyst in the head of the pancreas causing a compression of the common bile duct. If a cyst is seen in a patient with a new onset diabetes but without a family history. If the patient has got pancreatic type pain in conjunction with weight loss, then these patients can have a high-grade dysplastic lesion or a pancreatic adenocarcinoma and have to be evaluated by a cross-sectional imaging study, such as a CT scan or a MRI. In some patients with pancreatic cysts, if they have a family history of multiple endocrine neoplasia or a one Hippolyndose disease or a HNPCC syndrome, Peutz-Jeghers, or if they got a BRCA mutation or a familial melanoma syndrome, then these patients, when they have a cyst in the pancreas, they are more than likely to be an IPMN or a pancreatic ductal adenocarcinoma, more than likely an IPMN. So if you see a patient with this personal or family history, then these cysts should not be considered as benign cysts. These are high-risk cysts and they're likely an IPMN. So if you see a patient with a pancreatic cyst, what do we do to these patients? If on a CT scan or a MRI done on a patient with obstructive jaundice and there are cysts in the head of the pancreas, or if there's a solid component or a mass within the cyst, or if the main pancreatic duct is more than 10 millimeters, these patients require no further workup. Based on these three findings, if they are good surgical candidates, they should be referred to a surgeon for a Whipple procedure or some sort of a resection procedure based on where the pathology is located. There are some features on a cross-sectional imaging in a patient with branch duct IPMN that might require evaluation by EUS. So if you see a cross-sectional imaging, and if a cyst is more than 3 centimeters or equal to 3 centimeters, if the wall of the cyst is thickened, particularly if it is non-uniformly thickened, if the main pancreatic duct is between 5 to 9 millimeters in conjunction with a non-enhancing mural nodule, or all of a sudden, if you find an abrupt change in caliber of the main pancreatic duct, for example, it's a 3-2 millimeter duct in the head and the uncinate, and then it becomes 9 millimeters. And if you don't see anything near that area of transition, one has to be very concerned about an underlying neoplasm. And finally, if patients with these characteristics have peripancreatic lymph nodes, then all these patients should be referred for EUS, because cross-sectional imaging is not providing you an answer. It is just giving you these morphological changes, and it is our job to do EUS in these patients to ensure that there is no underlying cancer that is responsible for these morphological changes on cross-sectional imaging. When you perform EUS, what do you look for in an EUS? So the most important thing is general morphology. You want to look at the number of cysts, the size of the largest cyst, and the location. When I mean location, is it in the pancreas or outside the pancreas? Because sometimes you can have lymphoepithelial cysts and other cysts very adjacent to the pancreas that on a cross-sectional imaging appears like a pancreatic cyst. So that's one. Second, it's important to look at the wall of the cyst to make sure there is no thickness. We need to check for mural nodules or any associated mass within the cyst lesion, because these are harbingers for malignancy. The third is you need to define the cyst, whether it is macro or microcystic. So if the cyst component is less than 1 millimeter, it's micro. If it is more than 1 millimeter, it's macro. One has to check for septations, particularly if it is thick in particular locations, because that could be an indicator of a dysplastic change. It's also important to check for debris, because if it is debris, then it's a pseudocyst, or for the presence of mucus, because then if you find a mucin plug, it's a mucinous neoplasm. Finally, it's important to study the main pancreatic duct characteristics, the diameter of the cyst, the communication of a pancreatic duct with a cyst, the presence of mucin plugs or mural nodules within the main pancreatic duct, and any focal dilation. So these are the morphological features that must be critically documented. After we do that, it's important to see if any of the cysts is becoming malignant. And these malignant transformations will be explained by a thickening of the cyst wall or a thickening of the septum, the presence of a mass or a nodule within the cyst, then this is a cancer cyst. Then you look at the main pancreatic duct. If there's a focal dilation, if it is more than 10 millimeters, or if it is in between 5 and 9 millimeter in conjunction with a mural nodule, then you are calling malignant transformation of a cyst neoplasm. However, despite all of these characteristics being documented, the overall accuracy of EUS morphology is only about 50 to 70%. In other words, in about 30 to 50% of patients, we make an inaccurate diagnosis. Even more worrisome is the fact that we are not very good in diagnosing a cancer within a cyst, and we diagnose cancers within a cyst accurately only 25% of the time. So because of this, one cannot depend on EUS morphological characteristics alone to make an accurate assumption. So these are 3 videos. And when we look at pancreatic cysts, one of the most telling features is we talk a lot about a mural nodule, but it is not that easy to differentiate a mural nodule from a mucinous cyst. So in this particular patient, in the pancreatic head region, there's a cyst that measures 3 by 2 centimeters. And you see in this anechoic cyst, a hypoechoic area at the bottom with an hyperechoic internal rim. So if you are not sure, the most important thing is to perform an FNA. And when the FNA is done, it moves away. So this is not a mural nodule at all. What we see is more than likely a mucin plug. It's a mucinous neoplasm, but it is not a mural nodule. And these patients very often, if there are no other high-risk features, and if these patients are at high risk for surgery, can be safely monitored. But if you are not very clear, another way to differentiate that is by doing contrast-enhanced studies. In this particular case, one thinks that there's a mass at the bottom of the cyst. And this looks like either a mass or a mural nodule. Now, contrast is being injected. And when contrast is injected, you can see that there is absolutely no change within the cyst lesion. So this is a non-enhancing nodule within the cyst, and this is not a high-risk feature. On the contrary, in this particular patient, there is some sort of an hypoechoic area in the middle. It's still not very clear what it is. But once contrast is injected in this particular patient, very quickly you will find that this area opacifies and enhances very quickly. And this is an enhancing nodule. And this is very concerning for a mucinous neoplasm with a mural nodule that requires probably a surgical evaluation because of its enhancement. So after these morphological characteristics, when would you perform EUS-guided sampling of a pancreatic cyst lesion? EUS, while it can be used to evaluate a cyst, sampling should not be performed routinely in all patients. Sampling should be performed in 3 circumstances. 1, EUS and CT scan and MRI cannot achieve a diagnosis just by morphology. Then we need to sample. The second is the biopsy that is being done should alter patient management, i.e., if your biopsy shows cancer, and if that cancer is going to make you treat the patient with chemotherapy or surgery, then it makes sense to perform a biopsy. On the other hand, if the patient is 89 years old, and if there's a mass, and if you're not planning to treat, then there's no need to sample this patient. And finally, the third important feature is a concerning features. If you've got a dilated duct, change in caliber of the duct, the cyst is large, there's a thickened wall, there's a solid component, and if CT scan and MRI or EUS are unequivocal, then you should perform a fine needle biopsy to establish tissue diagnosis. How do you sample a cyst lesion? So generally, when you look at a cyst, and if the main pancreatic duct must be sampled, never use a 22 or a 19 gauge needle. Always use a 25 gauge FNA needle because it's fairly atraumatic. And in fact, I would also recommend giving the patient rectal indomethacin because although there is no evidence, it has been shown anecdotally to decrease the risk of post-instrumental pancreatitis. So we use a 25 gauge FNA needle when a duct must be punctured in conjunction with the rectal indocin. If the cyst is otherwise a simple cyst, we always use a 22 gauge FNA needle because it pretty much will get the job done. If the cyst has got a solid component and you suspect cancer, then a 22 gauge FNB needle can be used and there is no problem. If the cyst is located in a very difficult location, like the uncinate process of the pancreas, or you've got an intervening pancreatic duct, or if you've got a vasculature that must be punctured, and there is no way you can establish a diagnosis with a biopsy, then a 25 gauge FNA needle is okay. When do you use a 19 gauge needle? A 19 gauge FNA needle should be used only if you are using through the needle biopsy forceps. This is being manufactured. This biopsy forceps called Moray forceps is manufactured by US Endoscopy, which is now owned by Erros. So if you do that, then you can use a 19 gauge needle. Or if you're going to use confocal endomicroscopy probe for studying a cyst, then you can use a 19 gauge needle. So this slide covers all the needles and the circumstances under which a needle should be chosen for performing tissue sampling. There have been some studies that have suggested a relationship between a cyst puncture and pancreatitis. And we all know that when we sample a solid pancreatic mass, there's actually no risk for pancreatitis. But when you sample a cyst, particularly a branch duct IPMN, there's a 5 to 10% chance that we can cause pancreatitis. There are no studies that have shown a particular needle is at a higher risk for causing pancreatitis. In this meta-analysis that was done, it was not statistically significant, but what it tells you is when you use a 19-gauge needle, it appears that the chances of getting a pancreatitis is slightly higher than a 22-gauge needle, although it was not statistically significant. So the take-home message is use a 19-gauge needle if you have to. If not, a 22-gauge needle will get the job done with possibly less chances of pancreatitis. After you do a sampling, what are the principles for investigation and what will you order? There are a few things that should be done. If you do a CEA, and if the CEA is very high, particularly if it is say 800, or if it is very low, like 15 or 20, then it narrows the diagnosis. It's either a mucinous cyst or not a mucinous cyst. If it is somewhere in between, we look generally at a number of 180 or something as a cutoff point. It's not very accurate. It's about 80% sensitive, but highs and lows can be very helpful. If the amylase is less than 250, then definitely you know it's not a pseudocyst. You don't routinely order cytology on all patients because very often cytology comes back positive. You can check for mucin if it makes a difference. But if you don't see mucin, it doesn't mean it's not there. So in our practice, we order cytology routinely if there is a concern for high-grade dysplasia or cancer. So when you perform a cytology, make sure that the needle is located near the periphery of the cyst by the side of a wall. You can tap the patient a little bit, or you can sample the wall. Your yield may be higher. If the needle is going to be at the center of the cyst, and if you are just aspirating fluid, then cytology is not going to be helpful. You use a through the needle biopsy only if you see a mass, if there's a nodule within the cyst, or if the wall is thick. Then you perform through the needle biopsy forceps. You don't routinely biopsy all cysts because it can be risky. Molecular markers can be helpful, but they are expensive. And you use molecular markers if all of the above is inconclusive. So if you choose molecular markers, which molecular markers will you use? So your take-home message is there's something called safe sequential yes. So this will detect mutant alleles in 0.01% of patients. Therefore, this is most accurate. And if you don't have the safe sequence S, then you can use next generation sequencing because it will also detect a large number of alleles, and you might narrow down to only 4%, but it's much better than other commercially available routine products. So my recommendation is to go for the safe sequential yes, and if that is not available, go for next generation sequencing, because even if the allele mutant rate is as low as 4%, it's going to capture, and that's pretty good. So what are the test characteristics? Your CEA is about 80% specific, but unfortunately sensitivity is only about 65%. Also, the problem is the cutoff levels vary. Some people in some labs will have it as 180. Some people will have it very high or very low. But in general, the more the higher it is, the more the specific and sensitive your testing is. Glucose is quite inexpensive. It's more accurate and more sensitive than CEA. It's much cheaper. But the problem is, how do you test it? Are you going to use a glucometer? Are you going to use a test reagent? Or are you going to send a lab with different reference values? And this is the problem with the glucose testing, because there are too many ways to measure glucose levels, and low levels are suggestive of a mucinous neoplasm. And unfortunately, we don't have a gold standard for testing. Molecular markers are very good. It's highly specific and sensitive. And if you're doing molecular markers, check for KRAS and GNAS. And they're very specific for mucinous neoplasms, particularly GNAS, because if you've got GNAS positive, then it means it's an IPMN. If it is KRAS positive, it could be either IPMN or a mucinous neoplasm, but they're pretty decent testing. However, KRAS and GNAS will tell you that this is a mucinous neoplasm, but it is not going to tell you whether there's an underlying cancer. And to detect an underlying cancer in a cyst neoplasm, in addition to KRAS and GNAS, you have to look for alterations in TP53 or PIK3CA or PTEN. And if any of these three things are positive, then you're going to detect, in addition to mucinous neoplasia, in addition to mucinous neoplasm, advanced neoplasia within the cyst, and this can be as high as 90 to 100%. The problem is availability of the test and the expense that goes with it, because many of them are not covered by insurance. If none of this is working, then obviously you do through the needle biopsy with Moray forceps, and I've explained to you. If you've got a mass within a cyst, or if there's a thick wall, or if there's a mural nodule, through the needle biopsy forceps is much better than an FNA needle. It gives you better tissue yield. It makes a much better diagnosis of mucinous neoplasm, and it will diagnose advanced neoplasia much better than a FNA needle. Confocal laser endoscopic microscopy is a good test if you're an expert in performing this procedure. It's a small probe. You give the patient fluorescein, and then you check the imaging characteristics. There is a learning curve. And in this study of 144 patients in whom in 50% surgical pathology was available for comparison, they found that the sensitivity and specificity were very high, more than 90%, with an accuracy of 97% for diagnosing mucinous neoplasms. And you can see all these frondy projections within the lesion that are suggestive of mucinous neoplasms. And it is accurate more than a cytology and CEA. Once again, availability, training, and cost are important factors. And if you're not well trained, you're going to miss the diagnosis. So this is a study that looked at, compared different modalities. So you got FNA cytology. If you go only with cytology, then your yield, your diagnostic yield or accuracy is only about 16%. If you use your composite standard, which is imaging and radiological characteristics as your clinical suspicion, then it's about 34%. If you use your microforceps biopsy in conjunction with your composite, your clinical suspicion, then it can be as high as 75%. And if you combine confocal endomicroscopy with a biopsy forceps and then your composite clinical standard, then you can get a diagnosis 85% of the time. So all that this tells you is that the more number of tests you add, you have a better outcome. So in clinical practice, if you have nothing, then you just send it for CEA, and you check for amylase if possible. If your risk is high, on the wall is thick, you can check cytology. If you've got Moray forceps or through the needle biopsy forceps, you can get an accuracy of close to 75%. If you add confocal microscopy, then you get 85%. But if you've got access to molecular markers, then probably you can do the basic steps and go with molecular profiling with KRAS, GNAS, and add the other tests if you suspect cancer. Then you'll get a diagnosis close to 90 to 95% of the time. Another important thing is surveillance controversies. There are multiple recommendations on how to survey the cyst. The American Gastroenterology Association tells you can stop the surveillance if there are no high-risk features and if the cyst is stable at 5 years. The American College of Radiology tells you can stop surveillance at 10 years. But we know from the Japanese data that was published recently, then in branched at IPMN, you diagnose pancreatic cancer 3.3% at 5 years. And if you follow them for 15 years, that risk of cancer detection goes by 15%. So therefore, if you stop surveillance at 5 years, we definitely will miss some cancers. And in general, at any point of time, pancreatic cancer is found in only 1.1% of patients with pancreatic cyst neoplasms. So it's very, very difficult to develop a consensus based on available guidelines. But all that we can tell is you should not survey a patient unless the patient is a surgical candidate, because the whole reason of doing surveillance is to send the patient to surgery if they develop a risk factor. If you're going to survey a 93-year-old patient who will never go for surgery, then you're wasting money and that clinical information is not useful. So you do surveillance until a patient is a surgical candidate. And when they stop being a surgical candidate, you stop surveillance. And this is a study that explains you why that is important. This is a study on about 1,800 patients, of which they found deaths. And all these patients had pancreatic cysts. There were about 43 pancreatic cancer deaths. And these patients were categorized to 4 groups. Low comorbidity, low risk pancreatic cyst, low risk pancreatic cyst, high comorbidity, high risk pancreatic cyst, low comorbidity, high risk pancreatic cyst, and high comorbidity. And what you will find is that only in those patients who have a high risk pancreatic cyst but low comorbidity. So if these patients are very healthy, but if they have a high risk cyst, you stop surveillance and send them to surgery. If you've got a high risk patient with a high risk cyst, you're never going to operate, so you stop the surveillance. The patient has got low risk cyst and low comorbidity. You can survey them for 5 years, maybe. You can stop it, but I would recommend surveillance until they are surgical, until they remain surgical candidates. If you got a low risk cyst in a high risk patient, even if the cyst is low risk, there's no point in surveying this patient. So more than likely, you should stop surveillance. So this was the reason that I wrote that editorial where we say that you stop looking at the cyst and start looking at the entire patient and risk stratify them regarding surveillance. Then I think you will make a much better clinical judgment and get more meaningful outcomes. So again, when you look at the guidelines that have been developed, there are 5 guidelines that we commonly follow. The Japanese guidelines are meant for IPMNs. The European guidelines are for all neoplastic cysts. The AGA guideline for asymptomatic cysts in the pancreas. The ACG guidelines are for pancreatic cysts, and the American College of Radiology guidelines are for incidental cysts. So each guideline was actually targeted for a different subset. And the surveillance, as you can see, also varies. The Japanese and European guidelines recommend lifelong follow-up. AGA wants you to stop at 5 years if there is no change. ACG recommends a review at age 75 and then to make a determination. And then the ACR guidelines tell you if things are stable at 10 years, you can stop surveillance. But once again, there is no consensus. So what do you do in clinical practice? I think in clinical practice, if you see a patient with a pancreatic cyst neoplasm, they've got clinical features, you get a good history that we talked about. If there's a jaundice secondary to the cyst, or if there's a malignant change, they'll go directly for surgery. If it's a serous cystadenoma, or if there's a benign appearing small cyst, then a serous cystadenoma, you don't do anything. For a small branch duct IPMN or a low risk main duct IPMN, you put them on a surveillance. If you don't have a diagnosis, and if there are no high risk features, if there are high risk features, they go for EUS. On an EUS, if it's a classic imaging and you don't find any risk, just put them for a surveillance mechanism. If the diagnosis is unclear on EUS morphology, and if you're worried about an underlying neoplasm, you perform an FNA. You do CEA, cytology, molecular markers, if it is available. And depending on the risk of a cyst, you perform a through-the-needle biopsy or confocal endomicroscopy. If it is an IPMN or a mucinous neoplasm, no concerning features, they go for surveillance. But if you find a high-grade dysplasia or a cancer, they go for surgery. So to conclude, pancreatic cysts are all neoplastic, unless proven otherwise, but they are best evaluated and managed before they become malignant. Patients with high-risk features should directly undergo surgery. There is no need for EUS. EUS is only reserved for patients with unclear diagnosis, or if the findings of EUS, if you think is going to alter subsequent management. You sample a cyst when EUS morphology is unclear and there are high-risk features. The simple tests to perform are CEA, amylase, cytology if you suspect an underlying neoplasia. The second line tests will be through the needle biopsy forceps or confocal laser endomicroscopy if there's availability. And if payment is not a problem, and if your lab can perform the test, molecular markers will be very useful. You do surveillance only if a patient is a surgical candidate. If they are not surgical candidate, then you don't do any surveillance for these patients. And finally, this is, I know many of our friends from Brazil attend our live endoscopy meeting. And for COVID, we never had anything in 2019 and 2020. So we do have a program in 2022 where we have, as you can see, international faculty. This is not an EUS meeting, but we've got Bergman, Burke, Dupre, Falcons, Itai, Neuhaus, Dr. Reddy, Rapici, Roche, and Yahagi and Yamamoto coming from Japan. It'll be a 2-day live transmission with a hands-on lab and so forth. So if you have the opportunity, I would like to welcome you to come to Orlando, to come visit with us in our new hospital and the new unit and enjoy the conference with us. So with that, I'm now going to open this up for questions.
Thank you, Cheyenne. Fantastic presentation. I'd like to introduce Dr. Celso Arden and Dr. Luciano to start for the discussion.
Okay.
Celso, por favor.
Okay. Good evening to all participants, members of this webinar, and especially for Dr. Cheyenne, who gave us a beautiful lecture for the mistakes on pancreatic cystic lesions and how to avoid them. I think this is a really important chapter of these lesions. I want to thank the Professor Eduardo Guimarães Moura and the President of SOBED, Dr. Eduardo Dibi, for this invitation. And congratulations for your excellent class, but I would like to ask a few questions. Dr. Cheyenne, when exactly do you take the US FNA in patients, for example, with lesions, pancreatic cystic lesions in the head of the pancreas?
Only under 2 circumstances. If I think that the patient is going to be a surgical candidate and will undergo a Whipple procedure, then I will perform a biopsy. Or if the oncologist will tell me that I need tissue diagnosis because I think there's an underlying cancer, then I will perform a biopsy. The third is if the patient wants to know, sometimes they will tell me, yeah, I don't want, I haven't made up my mind. It really depends on what you're going to find. And if I'm not sure, I will perform a biopsy. So those are the 3 circumstances. But if I find a patient who comes to me with jaundice, who's not going to undergo treatment, and CT scan could not be performed, and if I see a big cyst with a huge mass, and if my biopsy is not going to make any difference in care of the patient, then I don't sample.
Okay. Another question, do you believe that there is a place of AUSFNB with core biopsy in this algorithm to the diagnosis of, to obtain a classificatory diagnosis of these patients?
I think if there's a mass, if we make a diagnosis to sample a lesion, and if there's a solid mass within the lesion, we all know that FNB is much, much, much superior than a FNA. Then I think FNB is the way to go. And this is particularly true for anything that is more than 10 millimeters in size, because if that's a mural nodule that is more than a centimeter, there's a 85 to 90% chance there's an underlying cancer. And FNB performs much better than FNA. So then you sample, yes.
Okay. Another question that I have, we know that the GNAS and CAHAS can diagnose malignant pancreatic cystic neoplasms. Do you routinely search for this marker in your patients, or do you have any special patients to obtain these markers? If you have special patients for this, to obtain these tumor markers, which patients do you use this technique?
So for a lot of patients who say, for example, have an 18 millimeter cyst in the body of the pancreas, 67-year-old, it becomes very tricky now because insurance doesn't pay. The testing can be $5,000. My diagnosis will not impact anything. Even if I tell the surgeon, KRAS positive, GNAS positive, it's a mucinous neoplasm, it doesn't change anything. And then they will tell me, okay, thank you. And you continue to survey the patient. So I don't do it. The patient in whom I definitely do it are patients who go for transplant. So although it has not been proven, it has been shown that patients with pancreatic cysts who undergo a transplant surgery, like a renal transplant or a liver transplant with immunosuppression, some of these cysts become a cancer. It has surgical implications. So when they go for something like a major decision like that, then I sample the cyst and I send it for KRAS and GNAS mutations. Okay. I just do it routinely.
Okay, thank you very much for your explanation. Luciano, do you have some questions too?
Yes. First of all, Dr. Cheyenne, congratulations on the excellent presentation. And I would like to say that for me, it's an honor to be in a session like this with such important experts. Thank you, Sobed, for the opportunity, especially Dr. Eduardo Moura. Well, we always have some doubts when we talk about pancreatic cyst neoplasms. One of them in my clinical practice is when we make a puncture and we get a small amount of liquid to analysis. What should we do? CAA, nothing.
Problem. So if you've got, depending on the lab, there are some labs in the United States, there's a lab called RedPath. So all that they need is just a single drop or two, but it's very expensive. Most labs will tell you they require a minimum of 1 cc of fluid to do whatever testing that can be performed. So if I get nothing, and if I just get 1 single drop, it's a waste. So what I do is, unfortunately, I'll put it on a slide and then you try to do the string test because it might be useful. If it is very, very sticky, we know it's mucinous neoplasm. The second I will do, if I just have a single drop, and if I have, we have a cytotechnician in the room, then I will tell him to smear it and to check for mucin. Those are the only 2 things I can do. If a patient is an alcoholic and there is a history of pancreatitis and so on, and there is half a cc, then I will send it for amylase because that will help me. CEA, if I get anywhere like 0.6 to 0.7, but less than 1 cc, then I will try to send it just for CEA. Ideally, to do everything that you want, you require more than 1 cc and 2 preferable.
Thank you, doctor. Sometimes we have peripheric cysts. And what can you tell us some tips to puncture this kind of cyst, peripheric?
You're talking about a cyst that is peripheral in the pancreas?
Yes.
Well, the cyst that you will have a problem, there are only 2 cysts that you will have a problem puncturing. One, a very low-lying uncinate cyst. They're very difficult. Getting a needle down in the second portion of the duodenum can be very challenging. Only a 25 gauge needle works excellent in the second portion of the duodenum because it can come out in any angle. The problem with the 25 gauge needle is that it will not aspirate fluid, particularly if the fluid is mucoid. It's going to get clogged. So if you're having an uncinate cyst that is very small, but if you have to sample, then I will recommend a 22 gauge FNA needle. The needle should be affixed to the scope when in the stomach. You should eject the needle out a little bit, out of the sheath, retract it so that only the tip is seen. Then you go through the pylorus to the second portion and you shorten. There's a much higher possibility that the needle will come out and you can sample a low-lying uncinate cyst using a 22 gauge needle. That's one. The second cyst that can be very difficult to sample is a pancreatic neck cyst. So this is called the no man's land. These cysts are by the neck of the pancreas. They come in and out, and they will be generally seen as you retract the scope. So you will see it somewhere in the bulb, and then the scope falls into the stomach, and then you've lost them. Those cysts can be very, very challenging to FNA. You will find them in some angles from the apex of the duodenal bulb. I would also, again, in those circumstances, tell the technician to brace the scope once the cyst is found in the mouth of the patient. And when you puncture, not let the scope recoil, because the scope always recoils and then you lose them. But one nice thing about a cyst is this: 99.9% of the time, these are not cancers. You're only performing the biopsy because you want to know whether it is a mucinous or a non-mucinous cyst. So if a cyst is very small and if it is very complicated, I will not push my luck too much. It's very important to make sure that you're not causing any damage. Most cysts are asymptomatic. What is wrong is to biopsy a very challenging cyst that is at very low risk for developing or becoming a tumor, and to give the patient post-FNA pancreatitis and create a problem. So, if you, under those circumstances, if you really have to sample, then you give them indomethacin, you give them a lot of IV fluids, and then you take your chances.
Another question, Cheyenne. For example, maybe we can find one patient with a oligocyst in the head of the pancreas without jaundice, without acute pancreatitis, and this patient has an epigastric pain, for example. The lesion in the MRI or CT has approximately 1.5 or 2 centimeters. What do you think the use of AUS FNA or AUS FNB in this patient? For example, a patient, not old patient, a patient with, for example, a 43 years old, a male patient in the lesion, oligocystic, a beautiful lesion in the head of the pancreas. And the surgeon, wants to do the AUS FNA. What do you think about this case? What is your conduct in this case?
I think I'll first go back to the CT scan and the MRI, and I will just talk to the radiologist outright. What do you think? I think the MRI is sometimes much better because it gives you a good relationship between the cyst and the main pancreatic duct. If the radiologist tells you, I just have a cyst in the pancreatic head, it is not at all communicating with the pancreatic duct, then we know that this is probably a benign cyst of the pancreas, or this could be a serous cystoadenoma. We know it is not on the tail, it is not a female, it's not a mucinous cyst neoplasm. We know that this is not a branch duct IPMN. In those cases, I will tell the surgeon, my biopsy in any way is not going to give you the information that you need. What are you looking for? What are you looking for? And if he tells me it's IPMN, I'll tell him, no, this is not an IPMN. There's nothing here. It's a benign cyst in the pancreas. But if in some way he tells you, your decision is going to make me operate or non-operate on that patient, then that is what it will. It is very hard for me to imagine that a surgeon will say in a patient with an epigastric pain with a 15 millimeter cyst in the pancreas that is not communicating with the duct, there are no features of pancreatitis, the patient doesn't smoke, doesn't drink, there is no weight loss, I'm going to operate. They're not going to operate. I will just tell them, repeat a CT scan or a MRI in 1 year. And in 1 year, if it increases, sure, we'll do something.
Okay, good. For us, is an important rule that when there are many guidelines for the disease, it is because we don't know much about this natural story. For example, in the pancreatic cystic lesion, that we have a lot of guidelines for this lesion. In your opinion, what is the best guideline? What is the guideline that you use in your clinical practice?
I use the Japanese guideline, the Fukuoka classification. To me, non-evidence-based, but it gives me some comfort because there is data that if you stop surveillance, some of these has become cancer in 15 years. And that is probably one among the few guidelines that tells you survey these patients until you can't operate on them. I like that one. 2, that is also one of the guidelines that very explicitly gives you clear-cut criteria on when to do EUS, when to perform FNA, and so on. So I follow the Japanese guidelines, yes.
The Fukuoka, the actually Fukuoka guideline. Okay?
That's correct. Yeah.
Good. Yes. And what is the role of the CA-99 in this evolution of the pancreatic cystic lesion? What do you think about this?
So the CA-99 is a problem when it comes to pancreatic cysts. It's a good serological test for pancreatic cancer. It has got nothing to do with cyst neoplasms. When it comes to cyst neoplasms, all of our data is based on CEA. That is a problem. Suddenly somebody will do a biopsy on a CA and get a CA-99 on a 1.2 centimeter cyst in the neck of the pancreas, and that value will come up 89,000, and then everybody is worried. The problem is we have absolutely no data, and CA-99 in a pancreatic cyst means nothing. Unfortunately, we don't have data.
Yeah, I agree completely. Luciano, do you have some questions to Shaya?
Just one more question. Dr. Shaya, how about treatment, endoscopic treatment of these neoplasia cysts, pancreatic cysts? Ablation methods, what do you think?
So there are two things. There are only two types of ablations. One is people use RFA and some others use chemoablation. People used to do alcohol, but alcohol is gone. So if you look at RFA, there are about 160 to 170 cases that have been done around the world. I think if you find a pancreatic cyst in a high-risk patient that has a huge solid component in it, maybe you can do an RFA. I don't have convincing data to show that following RFA, yes, it disappears. The data we have will tell us your size is stable or it became marginally small. Therefore, it's very hard for me to wrap my head. If you do a Barrett's esophagus, I know that the Barrett's is a cylindrical organ. You are able to place your RFA probe 360 degree around it and you can witness it. Whereas with a pancreatic cyst, a cyst is a cylindrical organ. The probes that we have are single. You suck the cyst, you collapse the cyst, and then you burn the cyst, and you're hoping that that electrode has made contact with the entire 360 degree circumference of a cylindrical organ. Just defies logic. So therefore, it's very hard for me to convince myself. The second option makes sense, to aspirate the cyst, to lavage the cyst, and to put chemotherapeutic agents into the cyst. As we know, chemotherapeutic agents were designed to work in the bloodstream and in our bone marrows. How this chemotherapeutic agent will have the same mechanism of action on a cyst lining, I don't know. All that we know from existing data is that when you treat a pancreatic cyst with chemotherapeutic agents, it appears that in about 65 to 70% of the time at follow-up, not too long, maybe 2 to 3 year data tells us they can be small or they can be stable in 2/3 of patients. But there's no control data. These cysts don't grow. They grow, but they grow very slow. So the best study is to have a randomized trial where you put them on 2 groups. One group, patients are completely blinded to the treatment. The physician is blinded. You treat one group and another group has no treatment. You see them for 5 years. And even then, growth is not a surrogate marker of clinical outcome. It's going to be death. How many patients die from pancreatic cyst? It's very, very small. It's probably 1 to 2%. So these studies are done multi-center, long-term, 10 to 15 year follow-up. And we need to see what happens in 10,000 patients. Is that study possible? Possible, but it's exceedingly difficult. We endoscopists are not good in performing good clinical randomized trials that requires patience and a lot of science.
We have 2 questions for you. One question for Mariane Subaran from US. Is there any role of artificial intelligence for better predicting the malignant potential of cystic pancreatic lesion?
Yeah, I definitely think so. I mean, what we know is this. The smartest people don't become gastroenterologists, and the smartest gastroenterologists don't become endoscopists. Right? So therefore, we all have interpretation problems. We all think we are good in everything we do, but we all have interpretation problems. And the only thing the artificial intelligence will do is to minimize subjectivity. And how will artificial intelligence be excellent? Artificial intelligence will be excellent only if we train the computer algorithm with a surgical pathology, which means thousands of pancreatic cysts with surgical correlation will give us, I think, excellent algorithms. And if we do have an algorithm, then I think an AI will be fantastic. If we are going to develop an algorithm, say, for example, you tell me, you go develop an algorithm, I'll develop an algorithm, but that algorithm is going to be based on my common sense, which is close to 0. So I will tell it, to me, it looks like a serous adenoma, and I will feed that information. It's incorrect. So algorithm based on long-term, very, very long-term clinical follow-up or based on surgical correlation will be fantastic. And I think it will have a very positive role in cyst studies with close to 99% accuracy, and it will eliminate a need for a lot of these investigations. I think the concept is good. We are not there.
Okay, I have one more question from Ricardo Pessoa for Fortaleza, Northeast from Brazil. He asks you if you use the antibiotic therapy when you perform the punction and the cyst.
So we know the Spanish study, randomized trial, that said that giving antibiotics makes no use. But the fact of the matter is, our guidelines from our society tells us to give antibiotics. So for us, we always practice defensive medicine. We are worried about lawsuits, so we can't go by one randomized trial. So we give antibiotics, one. What I do may not be the best medicine, but I'll tell you what I do in my clinical practice. If I don't plan to biopsy a cyst, and if the patient comes to me, and I land up biopsying a 15 millimeter cyst in the body of the pancreas, then I will tell the nurse in the room, give a dose of Cipro, and I discharge the patient. I don't give them a oral antibiotic prescription, nothing. I give them one intra-procedural antibiotic, like what I will do if I put in a pig tube. If a patient comes to me for some reason on some antibiotic for a flu or something, then I will never give antibiotic to that particular patient. The only time I will give them a prescription for 5 days is if I go biopsy a cyst and I realize I get necrotic material, then I know, wow, this is walled off necrosis. It was a small walled off necrosis. I've instrumented it and I can cause infection. I don't want this patient to develop infective necrotizing pancreatitis. I put them on a 5 to 7 day dosage of antibiotics.
I have one more question. Vitor Nunes Arantes from Minas Gerais. Excellent lecture and discussion. One question for Dr. Cheyenne. Has he seen, and how often, young female patients under 40 years with pancreatic cysts with typical features for IPM in his practice?
Less than age 40, how often do you see? Not very often, to be honest with you. I mean, you will see, I'll see a cyst in the pancreas. The problem we have is this. You will have a cyst in the pancreas near the pancreatic duct that is 7 millimeters. And CT scans, as you know, on MRI are never always of great quality. They will tell a pancreatic cyst, young patient, and then she will tell the doctor, oh, I don't know, my auntie died of pancreatic cancer. I want to have an EUS. You do an EUS. And if you are not able to demonstrate a side branch IPMN, very often what we do is we have this tendency of doing defensive medicine. We will say branch duct IPMN. Once you give them a label of branch duct IPMN, they are stuck for life. And I think a majority of these pancreatic cysts, that's how we keep surveying them. So at least in my practice, this is how they get referred. And if I'm not sure, what I'll do is I'll immediately tell them I tend to go more aggressive. I will say it's more than likely a benign cyst in the pancreas, but I'm going to recommend a 3-year CT scan or a MRI, and if there is no change, I stop the surveillance. The only time I will continue surveillance is if I can document communication between the main duct or the branch duct to the cyst. Age less than 40, I don't see a lot. You might see maybe 1 a month or 2 a month.
Okay, last question before then I'll back for Celso. Celso Patrício from São Paulo. Is there any situation that one should puncture the main pancreatic duct?
So that is something that we're very scared of, to puncture the main pancreatic duct. So, no evidence again. I would not recommend you to do it either. But if I see a pancreatic duct in the head and the uncinate, that is 3 or 2 millimeters. And when it comes to the body, it becomes 9 millimeter. Then what I do is I magnify the screen. I become very paranoid and I go back and forth at that site of transition. And then if the patient is even minimally symptomatic or sometimes even asymptomatic, then I will tell my technician to open up the IV fluids wide open. I give a dose of indomethacin. I take a 25 gauge FNA needle and I will biopsy the site of transition looking for a neoplasm. Unfortunately, I must have diagnosed at least over the last, say, 20 years, maybe 10 to 15 cases of pancreatic cancer. And the last patient I diagnosed was a 3 millimeter pancreatic cancer that had a surgical resection. Yep, I go for it. I do it. There's no evidence, but I do it. If I don't do it, I will bring that patient and I will tell the patient, you develop weight loss, you become diabetic, anything changes. Don't even call your referring doctor. Call me directly, or I will, and I will also get a CT scan every 6 months.
Okay, Celso, go ahead, please.
Thank you, Eduardo. My last question is, you have presented numerous techniques to try to identify the cystic lesions of the pancreas. In your opinion, in your technique, what is the best technique that you need to use to obtain the classificatory diagnosis of the pancreatic cystic neoplasm?
So the most important thing is this: you should always begin your examination from the uncinate process, particularly from the ampullary orifice takeoff. Very often, you will find a pancreatic duct that is 5.6 millimeters. What is this? Is it benign dilation of the pancreatic duct? Is this ampullary stenosis? Or this is early change of IPMN? So the only way you can answer this is when the pancreatic duct comes out of the ampulla and its diameter is bigger or larger than the bile duct, you are dealing with IPMN. That's critical. If you got a bile duct that is 3 millimeters, you got a pancreatic duct that's 5 millimeters, as it comes out of the ampulla, there's no doubt you're dealing with your main duct IPMN. It's very low risk, but this patient has to be followed. So that is one that's important. The second is, as you go through the duct, the most important feature should be to look for focal dilation of the main pancreatic duct. If there is a focal dilation, then you, like an eagle, you need to come back and forth at it over and over to make sure there is no cancer hiding. The third will be branch duct IPMN has the lowest risk for progression to malignancy, main duct has the highest, and mixed duct is also very high. So if you have a dilated main duct and if you find some cyst, you need to differentiate whether it is pure branch duct, pure main duct, or if it is a combination, because that will alter surveillance guideline. If you find a nodule within the main pancreatic duct or a mass that you think, don't even worry about it. If this patient has got no features of chronic pancreatitis, the very important thing is this: differentiating chronic pancreatitis from IPMN. So that differentiation can be difficult. The single most important feature is pancreatic atrophy. If the pancreatic parenchyma is well preserved, this is not chronic pancreatitis. If you got a nice big pancreatic parenchyma, a big duct, generally it's an IPMN. Once again, go to the ampulla and pull back. If you've got a small stone occluding the pancreatic duct, game over. You just have downstream ductal dilation. It could be a 3 centimeter duct. You're still dealing with chronic pancreatitis. Therefore, if your take-home messages, always look and do your pull-through maneuver starting from the papillary orifice. Most problems are solved.
Okay, now, unfortunately, I need to finalize for this session. I'd like to say thanks for Luciano and Celso, fantastic event. And Chaya, what your message to young endoscopists who are starting in US?
So, I've been told by many people that I'm always politically incorrect. And I've been very cautious, but unfortunately, you have to be truthful. So when you learn endoscopy early on, one of the things that worries me a lot is trying to learn a lot in the shortest time frame and to say, I can do good EUS, I can do good ERCP, I can do fantastic poem, I can do STIR, I can do EMR, I can do ESD, I can do bariatrics. It's good. I mean, if you want to work in a community hospital, and there is no facilities around, you're the only person in your endoscopy unit. And if you want to be a jack of all trade, you can. It's very important to understand that what we are dealing is with human lives. And if you have an interest in being internationally known in what you want to do, then you need to focus and you have to be laser focused. And I can just give you one clean example. Peter Cotton. Peter Cotton did one procedure, ERCP, and he did it perfectly and he did excellent. And that's why he is still the most famous endoscopist in the world. So if you're doing EUS, don't do EUS because you've got a machine in the hospital. Don't do EUS because everybody else around is doing you. No, I think resections, EMR, and ESD prevent cancer. There's a lot of the disease. If I have to go back and practice my career all over again, I'll probably pick up resections and I will not pick up EUS. I picked up EUS because EUS was a shortage and I just continue to build on it. So my take-home message is this. When you start your career, focus on a single technology. And say, for example, you do EUS and you become in no time, you have Paul Falkens, Robert Haas, and there's nothing more in EUS you can do. Sure, then you can go and say, I want to do something. If not, focus on what you do. You'll be a very, very good endosonographer. That's one. Second is, you should, if you want to be an expert in what you do, you must always pursue clinical research. Clinical research, not write a paper to put it on LinkedIn. Clinical research makes you a better doctor. You ask difficult questions. Research is difficult. It's much easier to do a procedure, but doing good quality research is difficult. It requires discipline. It makes you a better endoscopist. So, those are the two recommendations that you will have for people establishing career. And the last one, never after graduation, look for a job within 5 years. You graduate, you join a hospital, stay for 5 years and just suck it up. Whether it is good, whether it is bad, no. You stay there and you learn, you go through difficult times, and in 5 years' time, it gives you invaluable experience. In 5 years, if you have taken 3 jobs after graduation, you got a problem.
Fantastic message. Thank you so much, my dear friend. I see you as soon as possible. Bye-bye. Thank you so much. Super obrigado, Celso. Obrigado, Luciano. Vocês foram fantásticos. Uma excelente.
Thank you very much.
Good night.
Thank you very much, Cheyenne. Really good.